everybody. Welcome to another podcast episode of Pharmland. I'm your host, Bradley Nelson, along with my co-host, Tom Davies. Tom, say hi.
Hey, good afternoon, everyone.
Today, we're actually joined by McKenzie Rice, who is a clinical pharmacist consultant with RxBenefits. And today, we're going to be talking a little bit more about how to help people be more proactive, looking at plans, their goals, their objectives, to find out what might work best and how we or how someone can look and determine from their plan, based off their objectives, what do I need to do to meet those objectives? But before we do that, we always have to remind everybody, what is Pharmland? Pharmland's here to serve up the freshest pharmacy information and insights to benefit advisors, employers, and anyone else looking for a better understanding of the industry. And as always, we try to take the biggest topics and dig deep, offering perspectives that you typically don't find elsewhere. Pharmland is brought to you by Farm to Table, an educational program from RxBenefits. So we're going to start with our question to think on. If you were to consult a broker or a consultant or a plan in terms of pharmacy benefits, what are the non-negotiables that you as the consultant would need to know about to make sure that you put the right plan with the company goals and objectives? That's a pretty lofty topic, but we're going to have McKenzie on to help us understand how do we achieve that.
Now, I think it's a lofty topic, and then taking into account what pillars are available to potentially utilize to ensure that there are cost containment strategies in place. How do you weigh that against member access? And so, McKenzie, really looking forward to the conversation on how do we balance this moving forward, and what is the approach for a group, a client, an employer? Is this a one and done approach, or is it something that should be reevaluated on a frequent basis? So, looking forward to the conversation. Thanks again for joining us, McKenzie.
Yeah, thanks for having me. I think when we're having these conversations with brokers and clients, there's really no answer that is right. So we have to, during that discovery phase, figure out what are their goals. What is it that they want for their employees? So in that discovery phase, some of the things we ask questions around is how sensitive are they to disruption? And that it definitely varies. So what I mean by disruption is really any instance where a member cannot get that medication exactly that was prescribed. There are some times where disruption is a little bit more, I'd say, more of a hurdle for the member to overcome. And there's sometimes where it's simple as a switch that happens at the pharmacy. The member didn't even realize it happened. It's just a simple ABC switch. So there are varying levels, but again, just coming down to that medication that was prescribed is not exactly the medication that was prescribed.
So you're talking about macro versus micro review. So if I'm an HR representative and I'm asking you questions, I'm probably going to be asking you questions of, well, my member's pill color changed, right? And that's kind of what you mentioned, I believe, when you said you might change the NDC or the National Drug Code of the generic medication that you're using. But I might say, well, hang on a second. We are looking at this PBM, but they don't cover this medication at all. They say we have to try this medication. This is the medication on their formulary. So how does that disruption, is that something I need to look at as an HR representative?
Oh yeah, because those are the members that will likely end up in your office. So it's important in those scenarios to have someone with that clinical sort of background to really take a look at these medications and determine is this a specialty med? And we kind of have a specialty medication that's not on the formulary, really understanding that disease state and the other medications that treat that condition. We can provide a little bit more background And depending on how sensitive a client is to disruption, sometimes the conversation of grandfathering comes up where a client may or may not decide to cover that medication for that member going forward. But there's always financial implications to that. If you cover a medication that's not on formulary, you don't get that rebate value. You risk your contract, your guarantees in the contract. So it's also a financial discussion.
Interesting that you bring that up, and Tom brought it up a little bit earlier. Really trying to balance between the accessibility of as any drugs that you want on one side of the equation, right? So it's like, oh, you can get anything, everything that you want as a member, versus how do I create a sustainable benefit and not pay too much so that everybody can have some sort of access to a prescription benefit. So I know we're talking about the extremes there of being very cost centric versus very member centric. So, what are some questions that you would ask as a consultant to a HR benefits person or a CFO of an organization to say, how can I help you determine what your goals and objectives truly are? What type of questions would McKenzie ask to try to get at that, to find out what they really are?
Sure. One of the things that I would ask is, what does your membership look like? Have you had a lot of turnover in the past year? What caused that turnover? If so, is it something that see Galaxy benefits and you might need to take another look at your pharmacy benefits? Or on the flip side of that, maybe they're acquiring another company, so expect a ton new employers to come on. So just taking a look at what they're doing from a membership perspective, and then also what industry are they in? Are they a health system, hospital? Because their employers are going to be prescribers, and they are very much knowledgeable of the healthcare system and might be more sensitive to some of that disruption we talked about. So just getting an understanding of what the client does, it really helps quite a bit.
And I think that's an extraordinarily wise call out, McKenzie, is the difference is based on the employer. We did some work while a previous employer where we managed the formulary directly and made formulary decisions. And I don't think at the time I truly understood the impact of the different employer demographics. We had school districts, for instance, where a large population of the employees within a particular school, freestanding school, are all seeing the same provider. So they were impacted more significantly than we'd anticipate outside of a group that may be utilizing various providers. So this one size fits all approach when it comes to formulary selection, right? This is not likely a wise approach based on the market as it exists today. So formulary management is one of the ways that you potentially contain costs. Another one is just overall benefits design with regards to the amount the member pays. So co-pays, co-insurance. How do you speak to variations with regards to that?
It's of course up to the employer how they want to structure that, and there's typically 3 tiers. So a generic copay, the preferred brands, or non-preferred brands, and what is a 4th specialty. That again comes down to the access, and they might be looking at what are their demographics, right? What is their employer type in making those copay decisions? And on the flip side of that, how does that line up with the industry standards?
Weighing that intended outcome, when you shift more cost to the employer, it drives down client cost. But the potential unintended outcome is lack of adherence, right? There was a study that was published, it's been a while, and in 2012, it said for every dollar increase in member pay portion, there was a 0.4% decrease in adherence. So you could take that and extrapolate it out. So if you saw a $10 increase in the co-payment, co-insurance, whatever the case may be, you're seeing around a 4% decrease in adherence.
I want to go back to something that y'all mentioned I thought was very interesting. Lumping things in with these all employer groups in the same bucket. We talked briefly about health systems, hospitals, and employers that might be a drug manufacturer, right? So you have those. But if I were to say McKenzie, let's compare two different groups. Let's just really put some meat to this. If I have a retailer that has a 30% turnover in their population because they employ a lot of younger people that don't access the benefit very often, and they're going to college and they're constantly in and out, so on and so forth, versus a school system that has a lot of retirees that they cover, and there is a union population. Those are two of the most different clients that I can think of. And if you were to make a recommendation, I'm assuming the goals and objectives would obviously be different, right? But let's look at two school systems that are much the same. Do you think a school system in Texas would be different than a school system in Washington State in terms of their goals and objectives?
I do. Yes.
And why would you think that? Just off the top of your head.
Location in the pharmacy networks. What pharmacies are available to their employers. You'd want to make sure that that pharmacy is a network for them, so that might decide where to go for your benefits. Another thing is that the plan out in Washington State might have differences in what they cover versus a client access.
Do you think they have the same applicant pool and the same pay scale? Things like that are entirely different, which to me, it's more of, well, I have to look. I think the bottom line of what we're talking about is when you're consulting with someone, you have to look at them on an individual basis and not try to lump them in with everybody else. Because in Texas with school systems, you have less of an applicant pool. And so it's highly competitive in the market, right? So there's highly competitive. So you want to make a benefit as rich as possible in some cases so that you don't have attrition, you have employee retention. Otherwise, you might have some issues where you're as a system, you might be having to pull people back out of retirement. And the older we are, just in general, the older we are, the more medications we take and the more issues we have, and therefore the more costly we may be as a member to a plan. So all these different puts and takes, it sounds like the bottom line is you just have to look at everybody individually. But we did have a question that did come in, McKenzie. We did have someone that wrote into us and said, when you're looking at industries, are there certain industries that are healthier populations versus less healthy populations? Are there certain industries that take higher amounts of prescriptions? And that could also be geographic, right? Do people in geographic zones tend to take more medications than other geographic zones, and so forth? Any insight into that?
I think that's a good point to call out, Riley, just based on where they live, right? There's data to support that if you're in a particular latitude, further north you live, the higher instincts of multiple sclerosis associated with where you're at geographically. And then genetically, is there vast variations in the genetics of a particular area that may or may not influence the types of medications that the membership may utilize? Or if you're, like you stated earlier, older population, is just to wrap this portion up. It's just being aware of the nuances within a particular client base. I think there's some other things that we could touch on a little bit. We talked about the importance of pharmacy network, to ensuring that if you have a client that has a large metropolitan population or suburban population, they're likely not at the same amount of risk for lack of pharmacy resources that you would find with a more rural population, and understanding that they may not have the same resources available to them when it comes to availability of pharmacies and ways to fill their medications. So pharmacy deserts is important for rural populations. Being aware of that and make sure that the membership is able to garner access or get access to the medication in time. There's other aspects to look at as well. Is not only do we talk about just the formulary coverage when it comes to tiering benefit design, but also what about the medication for weight loss or fertility, more of those elective benefits and how they may impact the population. How do you approach those conversations when a group has interest and would like your thoughts, opinions on coverage of weight loss or coverage of fertility, coverage of OTC products? How do you approach those types of conversations?
I first like to get context behind why. What's your reasoning for wanting to cover these? And, sometimes it's philosophical. They just feel like that's something that they want to provide to their employee, which is totally fine. In other instances, like I mentioned earlier, it comes back to just wanting to be competitive in the marketplace. And when we have these conversations, we cannot exactly predict utilization. We always say we don't have the crystal ball in this industry, but we can use some of the data that we have and really give them an idea of the number of members that might utilize a weight loss medication. And if they were to, what's that dollar amount behind that? So it's important just to use the statistics that we have available and apply a dollar amount to that, not because it's all about the dollar, but they want to keep their doors open so they can continue to give these benefits to their employees. So unfortunately, we do have to have those conversations. And are they prepared for that? And are they prepared for it year over year when the next big drug in that category comes out and we don't know the cost of that product yet?
And I think that's an excellent call out. Of we're placed in our position as managed care professionals to how do we predict what the market's going to do, right? And you just mentioned weight loss. Another good example is a medication for, uh, I'm going to butcher this, I always do, but non-cirrhotic, non-alcoholic steatohepatitis. It's called NASH, right? And you mentioned for those that have obesity issues that might want to do weight loss, that can be up to 40% of the adult population. But in a drug like a new one that came out, Rezdiffra, back in March, there's 6.5% of the U.S. adults that may have NASH, right? And the cost of that medication can approach over $57,000. So when you're having conversations, I'm assuming it's really important that people don't think, well, we don't want you to cover anything, right? It's educating that there is a benefit and there's a cost to the benefit. What's most important to you? How do you weigh that? So I think what you've mentioned, McKenzie, and Tom, what you've mentioned in terms of, is this the right formulary? Do I have the right benefit designs from even things from an accumulator, copay or co-insurance, medical versus pharmacy integration on accumulators, and understanding the geographic zone of where you're going to be. I know we're kind of hitting this over and over again, but I think it's important for this group to educate outside of within our industry, that looking at everybody in one bowl. If you pull out the jelly bean out of that one bowl, it's going to have a different shape, different color, different taste. And you have to look at that individual group instead of just looking at the bowl and saying everything's treated the same. So I know we've talked a lot about this, and I wanted to kind of throw that statistic out there of how very small things, very small approvals, what you might think is a small approval, can lead to a big consequence. So, McKenzie, if when you're having conversations with consultants and clients, um, are are they taking more of a reactive point of view or a proactive point of view? Are they looking at, oh my gosh, I got all these GLP-1s, I need to do something now? Or are they looking to you and saying, McKenzie, what can I do to prevent the next GLP-1 craze? And how does those conversations go?
I think that the GLP-1 craze is nothing that any of us could have predicted. It was simply social media. That's it. Social media area causing the uptake of these medications. And so I think that that was maybe a lesson learned for a lot of brokers and employers out there, that having the necessary cost containment strategies in place is now more important than ever, because now we've introduced social media into the next way of advertisement of these medications. So having that proper utilization management is key, so there are any surprises going forward.
What if we utilize social media to speak to prior authorizations, need for prior authorizations, benefit designs? Yeah, I think that the social media impact when it came to GLP-1s is nothing that we could have anticipated. But having that experience in the bag moving forward, what's the next thing? And making sure that clients are set up in such a way that there's ways to potentially mitigate the quote unquote next GLP-1 or the next medication craze.
So, McKenzie, if you had a client that historically it's very member centric, and because of certain instances like what's happened over the past couple of years, decided I'm going to add a utilization management rule for this medication class only, how would you make them feel more comfortable to look at more of a standard approach? Should you recommend a standard approach? Because after all, we are talking about how we want to create individual plans. How do you balance that conversation with those particular employer groups and consultants?
If I wasn't in this industry, I wouldn't understand the impact of one prior authorization over another. And what happens when you pick and edit here and edit there, there are going to be some high cost medications that slip through the cracks. I don't want to make this a conversation about GLP-1s, but it's such a good example. If you looked at those just 3 years ago, not everyone had prior authorizations on these medications, and that was fine. They weren't being used inappropriately, but things took a very swift turn in the past couple of years. And so when you have a client that was enrolled in a standardized utilization management bundle, where the plan or the pharmacy benefits manager is adding these edits on behalf of the employer, they didn't have to worry about adding these edits on themselves. So it creates a slow uptake when you choose just one edit over another, rather than it just kind of being the easy switch on happening at the pharmacy benefit management level.
For somebody that's spent a lot of his career in operations, customizations can lead to some pretty difficult conversations with regards to how do we best operationalize this, ensuring that there's no potential gaps or leakage stuff. So I think that's really wise approach by McKenzie with regards to how to have those conversations. And then, as you stated earlier, when it comes to these conversations you're having with groups, really understanding the intent behind the question. Is this just one bad experience? Is there concerns based on something they learned at an employer conference that they're looking to mitigate and they don't want to happen to their group of employees? I think truly understand the intent space. It really helps us to ensure that our solutions that we offer, our consultative recommendations, really fit for the client.
we've talked about a lot of these different things, and it's kind of like the balance between member-centric approach and cost-centric approach. It's also a standardization versus flexibility approach. And it really comes down to having conversations, it sounds like, McKenzie, just really finding out what makes this plan tick and what they truly want. I do have a question for you, though. Whenever we're talking about, I mentioned me being the HR benefits professional. It's not always that person that's making the decision, is it? That's part of the conversation. Um, Historically speaking, who have you seen that have been very beneficial at providing guidance on the goals and objectives for an individual client? What types of individuals would behoove us to ask questions of to see what the client really wants?
Sure, we have a lot of conversations with the broker because they've seen it all, right? And they can really interpret what the client was. They've built up that relationship. It's all about context. And a lot of times they can give us that necessary context and also give us an idea of what's going on with the employee. Maybe, one example, there's one that has a lot of HR turnover, right? And so they're trying to make some decisions for their new benefit year. And so the broker was able to tell us that sort of background, which to maybe some people, it wouldn't sound like a big deal. But in this setting, it really is a big deal because when it comes down to making those decisions, they can't be taken lightly, and often there are due dates.
Mhm.
And so it's good for us to have that relationship with the broker so they can really give us a third party view on the situation and really nail down what the employer is needing.
So needs change, McKenzie. How often would you recommend reassessing benefit design, formulary, prior authorization with the client? As the market evolves, I would assume the recommendation would be just one and done, and it should meet the needs moving forward. How often do you recommend for having conversations about reassessing, making sure that we're really getting the results that we anticipate?
Reviewing to see utilization is what's driving those conversations, and reviewing that utilization on a quarterly basis can be helpful to a client to make those decisions before things get out of hand and you're waiting to make that decision on the regular year. But I'd say at least on an annual basis, decide on making changes. One, a lot of people are expecting changes to their benefit. Most people know that your deductible starts over and that, oh, my money is going to require PA. It's time for that renewal. So most people anticipate that change come 1/1, but it is never too early to start tracking your utilization. Let's do that quarter over quarter so we can anticipate those changes that you want to make 1/1. And if you'd like to be more aggressive, and some clients are more aggressive than others, they might decide to make those changes even mid-year.
Really good call out, McKenzie, and I appreciate you mentioning the employee benefit consultant or broker and the relationship, because you're right, they are the gatekeeper for a lot of healthcare decisions, and asking them for their opinion and what they know about their client, because they do live it every day, right? And enables consultants to be able to provide additional insight in how to build a plan and to make it tied into the goals and objectives for the individual employer group. On the flip side, though, what can employers talk to their brokers about? How can they get across their opinions? Because in some cases, you may have someone thinking, well, it works for this client. It could work for this client. Does it go back to the original premise that we had is everybody's individualistic, and if you want to advocate what you want as a client, you need to have conversations. Um, how would you advise an employer to advocate for themselves with their consultant?
I think that it's important to keep them abreast on what's coming to your office, right? A lot of times that's reflective of the benefit. And if there's a trend, then maybe there's some changes that need to be made. If there's difficulties around, the utilization management in place, maybe it's time to step down that utilization management bundle you have. Maybe you capture those high cost specialty medications, but remove some of that utilization management on those branded products. Um, that have some lower cost alternatives available. So there's tweaks that can be made to that. And I think that just hearing what is coming from the patient is indicative of how the plan is running.
But solving for common themes, right? Common questions. And oftentimes when it comes to patients and numbers, if you see the spike in trades, is there something that's unusual that with regards to the feedback we're receiving from your membership that needs to be addressed moving forward? So we've really touched off on a lot today. I think my largest takeaway, and it'd be great to do one for each of you as well, is just do understand the decisions that you made in a vacuum. And the importance of revisiting the decisions on a timely basis. I think that was my number one takeaway, just to ensure that we continue to meet market needs, and then making sure that the access and affordability remain in place for clients and ultimately downstream members, patients.
Yeah, I think ultimately the context behind the ask is huge. What led us to this discussion today, and making sure that you use the data that you have and reviewing, like you said, Tom, that utilization more frequently than having to make a reactive response. You could really catch it up front. So being proactive in that review and using the utilization to really tell a story.
Well, I don't think I can add anything else to that. Proactive approach, having a good ear to listen to your clients, understanding who they are as a client and their goals and objectives, balancing member benefits with plan design. So there's a lot of things and using data to validate that not only did you make a good decision, but what's the next good decision that you have to make. And that's how you can determine whether or not you have gaps in care or gaps in your coverage, so that you can plug those gaps depending on whatever comes your way, right? Whether it's an economic situation, whether it's heated competition within your industry, within your geography. There's so many things that go into individual plan needs in terms of deriving their goals and objectives. So I think we can wrap up this session. McKenzie, we'll probably ask you to come back to talk a little bit more in the future about other topics related to being a consultant to plan sponsors and to brokers and consultants out in the prescription space. But certainly appreciate your insights today. And Tom, I always appreciate your insights, man.
I pay you to say that, everyone.
That's right. If I had $1 for every time I said that, I could actually just pass it over to Tom. All right. So we're going to close this episode of Pharmland. And for now, everybody take care. Until the next time.